Hello, everyone. I'm Carmel Shachar, the Executive Director of the Petrie-Flom Center for Health Law, Biotechnology, and Bioethics at Harvard Law School, and I am excited to welcome you to our event, Trends Transforming Advanced Illness Care, The Promise of Technology. This event is a collaboration between the Petrie-Flom Center as well as the Coalition to Transform Advanced Care. We are so lucky to partner with CTAC to bring you interesting, thoughtful events about the delivery of care for that kind of critical end of life, last year, towards the end of life care. This event is no exception. This will be a very lively discussion between our panelists, and we strongly welcome and encourage audience questions. If you're wondering how to submit a question, you have two ways to do it. The first and the best way is to use the Zoom Q&A feature. That button is found towards the bottom of your Zoom screen. If you click on it, it'll open a window, type in the question. The moderator will be looking at those questions and will bring them to the panelists. You are also welcome to join the conversation or to submit questions on Twitter using the hashtag #AdvancedCareTech. Again, that's hashtag #AdvancedCareTech. Please do not use the Zoom raise your hand feature. That little hand is really cute, but we will not be monitoring it. As well as please do not try to use the Zoom chat. So again, Zoom Q&A feature or Twitter. If you're interested in this event, we have a busy event slate that tackles a variety of really interesting issues. The best way to keep abreast of these events are to sign up for our newsletter. You can visit our website or use the QR code on the slide. We also strongly encourage you to read our blog, The Bill of Health, which translates some of the really interesting thought leadership and scholarship happening in health law and policy to make it really accessible. So we tackle whether your employer or university can mandate the COVID-19 vaccine. We talk about data use. We really cover the gamut of healthcare policy issues. As well as I would strongly encourage you to look up CTAC's excellent programming, including their National Policy Forum, which is happening on May 12th. It's virtual and the cost is free, which means that you can attend it in your yoga pants and it's not going to cost you any money. But even if you had to put on real pants and pay money, having attended some of these events, I would say it is undoubtedly worth it. With that, I'm going to hand the floor over to your moderator for this session, Sheryl Mathis, who is Senior Fellow in Advanced Care and Health Policy at the Petrie-Flom Center, as well as Strategic Advisor to the Coalition to Transform Advanced Care. Sheryl, the floor is yours. I think you might still be on mute, Sheryl.
Okay, we'll start over here. People in our country with serious illness often don't get the care they want and deserve. CTAC exists to solve that problem. We are more than 170 organizations nationwide working together so that all Americans with serious illness receive the care that meets their values and honors their dignity. We have a terrific panel of experts whose careers have been driven by the passion to help people with serious illness live the best life they can. And those are our speakers today. These innovators from different roles in care delivery are here today to grapple with the question, how does technology impact care for people with serious illness? Can it really improve the quality of care and the quality of life for everyone, not just those with money and access? And if so, what are the hurdles to overcome? How can we be successful in helping all seriously ill people live every day their best day possible? Our first speaker is Susan Ponder Stanzel, President and CEO of Allevia Care, an organization she founded to bring a full range of hospice, home health, and palliative care to communities in southeastern United States. Susan previously was the longtime CEO of Community Hospice and Palliative Care in Jacksonville. She founded Allevia because she saw the need to expand the scope and range of services beyond hospice and beyond hospice eligible persons. Next, we're going to hear from David Jones, CEO of Chrysalis Ventures, which he started because he saw the need to support innovative companies in the Midwest dedicated to providing better coordinated care. David did not start out in healthcare. He was originally an international State Department attorney over in China, but he returned home to help the company during a leadership transition and has remained as a board member of Humana and the Humana Foundation. He is passionate about the opportunity for entrepreneurs to bring about improvements in care, especially in light of the poor care his own parents received at the end of their lives. Our third speaker is Ravi Parikh, a practicing geriatrician, oncologist, and researcher at the University of Pennsylvania. Ravi started out in high school as a hospice bereavement counselor. He now works to implement novel delivery models of care for advanced illness. Ravi holds leadership roles in medical societies. He is a member of our CTAC board and is widely published with a specialty in translating technical medical information for a lay audience. A self-proclaimed techno-geek, Ravi is very interested in the uses of technology to improve care. After each of our speakers gives initial remarks, I'm going to ask them some questions, and they will have the opportunity to question each other. Then we'll go to audience questions, which you've been told how to submit. So let me start with Susan. Susan, tell us about your work and what you see as the impact of technology on high quality, person-centered care for all people with advanced illness.
Thank you, Sheryl. Well, the organization that I lead started 40 years ago as a hospice, and I think most of us on this Zoom know that hospice really began as a way to fill the gap in a medical care system that was very good at curing and fixing, but defaulted to the idea that there's nothing more I can do for you when that wasn't a realistic goal. And hospice really became that, here's what I can do for you. There is something that we can do to bring care and support to you. And 40 years later, it still offers that person-centered care that includes not only the patient and their whole being, but their caregivers, and focuses on something more than just their disease. That's something we're going to be talking about today. And while it's become a lot more accepted in the 36 years that I've been working with it, we still, as hospice, serve fewer than 50% of those who die in the United States. So it obviously still has some access issues. It's also a high-touch service that you don't automatically think of hospice technology. And one of the things that we had to face as an organization that serves over 1,300 hospice patients a day is when the pandemic came and we were going to wait it out. And then we realized, oh no, this is not a sprint. This is a marathon. We have to find ways to be present for our patients and families and keep our staff safe. We thought, well, we don't consider technology an ideal way to interact with hospice patients, especially to provide care, but perfect is the enemy of good. And we would rather be present and try to do good and figure out how we can use the technology that we had at hand to actually be able to deliver care during the pandemic. So we use things from providing bereavement support groups on Zoom to FaceTime to all sorts of applications, texting, virtual visits, to really be able to not only allow our staff to still see patients and families and remain safe, but families and patients weren't that eager to have us in and out of their house for those long periods of time when we weren't sure who might have the COVID and be asymptomatic. So we really had to try technology because of the circumstances of the pandemic. But what we found, and we're still processing the lessons that we learned, but we found that technology does bring some benefits. For instance, it can give our families immediate access to clinicians rather than them waiting for us to get someone in a car and drive to where they are after hours or in emergencies. And it can help us respect a family's desire not to have people in and out of the house. Some families are very private and they would prefer to interact with you in another manner. But we also found that there's no substitute for a human presence, particularly with our chaplain care, with our social work care, and as a patient near the end of life. So we're still trying to process the lessons that we learn and integrate what's good about technology, which is efficiency, more access, more patient control, into that high touch that is hospice care. And those kinds of lessons that we've learned can apply to any of the services that we offer. Our organization provides palliative care, advanced illness care, and has a PACE program as well as home care. And what all of these services have in common is that they focus on helping people live better with chronic and advanced illnesses, including geriatric frailty. When I first became involved in hospice in 1985, 90+% of our patients had advanced cancer. Today, 38%, 40%. The other patients in our care have the diseases like COPD, CHF, dementia, Alzheimer's, but not in proportion to their need. One of the gaps I see is end-stage renal disease. You're not going to find many patients with that utilizing hospice care. So there's a need for us to take what is good in hospice and translate that into more advanced care solutions, because clearly there is a gap. And as we continue to evolve our solutions and approaches, we want to look at what we can really take away from technology. One of the things that we focus so much on in any of the care that we provide is giving patients back control and autonomy, because any of you who've walked alongside someone who's had a serious or advanced illness know that at the end of it, you are feeling like a body that's had a lot of painful things done to it, or you are your disease. So giving patients control over how they want to access information, how they want to interact with us, and giving them support at the time that's convenient for them and not just for us. To me, I see those as wonderful opportunities that technology can provide. I think remote monitoring and wearables can offer us many opportunities to not be intrusive, especially for our older patients who want to age in place in the community, but to make sure that there's safety and connectivity when it's needed. And I think one of the biggest opportunities that I've seen that's really exciting is artificial intelligence and algorithms that help clinicians think about if the person that they're treating and caring for may really be more appropriate for a palliative track versus a curative track, because people don't go to medical school to think about that necessarily. They don't always recognize when someone who is in the last years of life is literally right in front of them. Just to give you an example, we're one of the largest hospices in the United States. Our median length of stay is 9 days. So where were people before they found us? Well, they were probably in our very fragmented and isolated system trying to figure out where they needed to be and hoping that someone would point them in the right direction. So I see that these predictive tools and triggers can really help us find a way not to get people so late to where they might receive help that's more congruent with their needs. And I also see technology as having great opportunity to help us mitigate our workforce challenges by making more efficient use of our staff time, and really not as a substitute for interaction, but as an adjunct and add-on, particularly in our rural areas, which we also have, being able to look at someone on a screen while a nurse is in the car on the way to attend to an emergency. And for caregivers, particularly those who are caring for dementia and Alzheimer's patients who have difficulty leaving the home, being able to provide them support either virtually or connecting them with one another, I think is a great opportunity. But, you know, one of the challenges that we're facing is the affordability, being able to deploy this technology, especially as a community-based nonprofit organization. I think what we've seen is that it's really exacerbated, or at least focused the gap that inequity and access for rural populations and lower income populations, and really helped us see that our system doesn't help support the deployment of technology. Medicare Advantage has a lot more flexibility in what they'll pay for, but as we've seen, Medicaid and Medicare fee-for-service haven't really embraced using technology as a way to provide care only during this public health emergency. So one of the things that I want to close with, Sheryl, because I'm going to stay on time, that 5 minutes is hard, is there's a fundamental issue, and I think it's important. We all know this, so I'm going to be Captain Obvious here, but technology isn't a silver bullet. It's another arrow in our quiver. It's another thing we can integrate into practice to improve the care that we deliver to patients with serious and advanced illness. But it won't address that fundamental systemic issue, which is a commitment to improving the care that people receive. Right now, we have a very fragmented system that's very frightening and isolating and lonely for those who have to navigate it. And we know how to do better. We can do better, but there hasn't really been a will to make the kind of disruptive changes that need to happen to allow that continuum of care to be created outside of the hospice benefit and further upstream in a patient's illness. So I'm hoping that technology might make that more affordable and more within our reach so that we can really do a better job of caring for a growing population of people who are living longer with chronic illnesses. And Sheryl, my hope is that by the time I'm at the point that I need that kind of care, we will have more options to really provide not just episodic care, but a real system of care that recognizes that the needs of those with advanced illness are different than the needs of those who are seeking curative care. So I hope I stayed in my 5 minutes.
Great. That's great. I want to see what David has to say.
All right, first I'm going to unmute and I'm going to start, Sheryl, with thanking you and CTAC as well as the Petrie-Flom Institute at Harvard for including me in this. This is the first time I have spoken publicly about advanced care or anything to do with this topic. So let me just say a word about why I'm here. As Sheryl mentioned, I went through my palliative care moment with my elderly parents, and I won't drag everybody through the specifics of that because I suspect the people who are participating in Zoom on this topic probably have, in most cases, their own experience with the topic. But let me just state at the outset, my parents did not receive bad medical care. They got great medical care. And I also want to be clear that the love and the caring qualities, the empathy of their clinicians and caregivers, I could give a separate talk on that and feel very strongly about the human qualities that were part of the journey. And I also I don't think I'm railing against, the existential reality that we all die. This is an emotional area, and I know it's easy to get thrown off track, but the core, and Susan did a good job already of setting this up, but the problems were lack of communication and lack of coordination in all aspects of the experience after a certain point in the progression into frailness or illness, but well before end of life was in view. And so, my father was the founder of Humana. He was CEO of the company for 44 years. We were in Louisville, Kentucky, the company's headquarters, where it's the largest employer. And I apologize for saying all that, but I want to make clear that the story here is, I think almost everybody does not know how to navigate this landscape. And so as I talk about how to try to apply my skill set, which is really my mission at this time of life, to encouraging, fostering, supporting innovation in advanced care, I do see it as a problem. It is especially acute for underserved, for people without the kind of privileges we have. There's no doubt about that. But our system still doesn't do a good job here. So let me just pivot from there and in the kind of brief intro, kind of say where I see opportunities that can be addressed, things that can be improved on. In every one of these themes, technology is a crucial component of it. Without the communications technologies, the bandwidth, the ubiquity of ways to communicate and monitor, and the analytical firepower of our predictive engines, things I see would not be possible. But in no case is technology the solution. Sometimes the solution is about changing payment modalities so that people can afford to coordinate and to communicate. Sometimes it's about creating platforms that are distinct from other parts. Anyway, let me just hit the high points, and if anyone is interested, we can come back in the Q&A. So the first issue is what I think of as patient and family knowledge, and then communication within the non-professional landscape. I mean, my experience was, I certainly didn't have a clue, and I'm a healthcare nerd. I'm the longest serving board member of Humana. I've been on the boards of 25 or so healthcare companies, but I had no clue about the progression into palliative, into hospice. I didn't know what those terms meant. I didn't know when. I didn't know what to look for. And my family didn't. Our friends were unable to communicate. The provider landscape has trouble with handoffs. We can have a separate talk about how fee-for-service, uncoordinated care in all aspects has weaknesses in coordination. But I think it might be accentuated in topics that people don't want to talk about very much. But some of the work here is not technology work. It's not business work. It's not even institutional work. It's how do we help, and CTAC has a great project in Louisville that I'm trying to be helpful with around working with faith leaders to change the dialogue and the kind of practical theology. So there are plenty of other ways. There's policy work to do, but just a couple of examples of startups that are going at other places. There's a company called Cake, which started out trying to create a cloud-based registry of advanced directives so that all of the players in the institutional system, all the family members could get access to know what people say they want. It's evolved, as I understand, I don't have anything to do with the company, but I've met with some of the people, to be more of a, peer-to-peer sharing platform and expertise platform about, what is all this end of life stuff about? That's interesting. Another issue, and there are a lot of folks trying to work on this, is how to get families to communicate, not at the end, but at the very beginning of the journey when the elder needs a little bit of help, and then to have those habits. A company called Avonlea Care is one of many that are trying to build good structures around this. Second topic is restructuring clinical enterprises and workflow. And there is a ton going on in the space between I go to see my doctor regularly and my doctor is proactively reaching out to me. Restructuring primary care, companies like Oak Street, Iora, there's a lot going on there. There also is a lot of analytics in the provider space. Humana is working very hard on identifying patients who are coming into transitional moments and might need a different kind of care. There's also huge opportunities in discharge planning, and I'm looking for a platform to do a better job of that. Finally, restructuring home care around integrated teams rather than the specialist dispatches, one after another, disparate nurses, is a huge need, huge opportunity. That's where most of Humana's work is going on. We just announced, actually yesterday, night before last, we were buying in the rest of Kindred's home health platform, the largest single agency in that highly fragmented market. We're also working with Heal and Dispatch, a couple of primary care and emergency care in the home companies. But the basic idea is to get these things under a Medicare Advantage platform so that the individual fee-for-service, unit-based economics can be shifted to allow people to do what's needed to be done for a longer time. There's also a opportunity for community-based providers in that, and a wonderful company called Votive Healthcare is starting into that. So there's so much opportunity to use communication tools to restructure the contractual environment so that people have the time to do what they want. I guess I'll just close by saying I will have a sense that we're getting better when we begin to see the turnover in home health nurses and aides fall, because the compensation structures allow them to do their best work in a more continuous fashion. Not all be paid one size fits all, per hour for whatever goes on, but actually be paid for the quality of the work and the relationship and the health outcomes they have. So I'll shut up and hand it back to you, Sheryl. Thank you.
Thank you, Dave. That's a lot to think about. So Ravi, what do you got to say here?
Thanks, Sheryl. Thanks, David and Susan, for those fantastic comments. I think it's really interesting how we're coming at the promise of technology from very different perspectives. I'm a medical oncologist. I see patients with cancer on a day-to-day basis, and so I wanted to just sort of paint a picture of what life was like pre-pandemic, which seems like ancient era, and post-pandemic, in which we've integrated technology into our day-to-day life. So take a patient who's coming into my VA clinic, a veteran with stage 4 lung cancer. Pre-pandemic, that patient would come in, draw their labs, wait half an hour for their labs to result, at the very least, come in to my office. I would assess their symptoms just at that clinic visit, and I would document their symptoms, do a physical exam, order a chemotherapy. That patient would wait in the waiting room for another half an hour potentially or more, and then they would go in, get their potentially hour to 2 hour long infusions and go home. And they'd have to do that on a recurring basis. Fast forward to during and post pandemic, where we've had to change up everything how we do in an effort to try to keep patients at home and away from being exposed in a potentially dangerous healthcare setting during the pandemic. So technology now influences everything that I do. Our symptom assessments that would normally be done in clinic, we're routinely getting those symptoms checked via remote monitoring platforms, oftentimes via AI-driven chatbots for patients in the community, where patients can report their symptoms at home, and I just have to take a look at a sheet. I can actually look at trends in symptoms over time, and it's much more objective than that singular sort of 1 to 2 minute assessment I was doing during the clinic visit. Take other types of remote monitoring. We now have pilots where we're engaging things like Fitbits and step counts so that we can accurately monitor how active patients are, because we know that activity is one of the biggest things that falls when patients receive chemotherapy. Take just something as transformative as even giving chemotherapy at home. The advent of home infusion, technology that's coupled with with nurses and other professionals visiting the home has enabled a large cohort of our patients during the pandemic to remain at home while they get chemotherapy. This used to be a completely foreign concept because we thought it was completely unsafe. And lo and behold, it's not for a large proportion of our patients. And so this is not going to be a fad. The pandemic has exposed a lot of fault lines in healthcare, but it's also exposed a lot of ways that we can use technology to keep patients where they want to be if they want to stay at home. And there's a reason why, even amidst a lot of the economic shifts during the pandemic, digital health startups, many of the ones that David was mentioning, had over $14 billion, that's billion with a B, of investment in 2020, and that number is going to skyrocket in 2021. Just behind the scenes, even outside of how patients get exposed to technology, we have a lot of ways that we can use technology behind the scenes to help influence the care that we deliver to patients. We've recently run a randomized trial using some of the AI-driven predictive analytics solutions that Susan was mentioning to try to identify patients with cancer who may be at risk for a future adverse event, even death. And using those assessments, try to direct certain care interventions to them, including simple nudges to oncologists to try to nudge them to have conversations about goals and wishes, including end-of-life wishes for their patients earlier than just the last few days before the end of life. And lo and behold, just using that type of nudge, that analytics-driven nudge, we were able to increase conversations by over 4-fold. these types of applications with technology are really going to be transformative into the way that we deliver care for patients and that patients receive care, that people receive care. Think about something as supposedly high touch as a palliative care consultation. We used to think that palliative care via telemedicine could never be done. Palliative care is a medical specialty focused on symptoms and advanced care planning, among other things, for patients with advanced illness. We used to think that palliative care could never be done via telemedicine because it requires someone being in front of you. Now, almost all of our palliative care volume at our cancer center is done via telemedicine with amazing results and amazing reach compared to how it was delivered before. You can't have a conversation about technology without acknowledging disparities in access to technology. And I'm hoping to address that along with the other panelists during the course of our Q&A. But I just want to say, I think just as of a potential barrier as access to technology is for communities of color, underserved communities, I think that the potential for technology to expand the reach of how we deliver care for particularly those same populations is going to be huge. And we need to balance that out before we paint technology with a broad brush. At CTAC, we've been best known for our policy and advocacy efforts. And so now, I now serve on the board of CTAC, and I've been kind of, it's been so amazing to see how some of the sauce is made when it comes to advocacy and policy. As David was mentioning, alternative payment models, different ways that we integrate different ways of delivering and paying for care are key for advancing technologies, because in a fee-for-service system, we're never going to be able to achieve the reach and technology that we are using novel methods of paying for how we do care. And we've been working at CTAC on empowering alternative payment models, both at the national and state level. But a lot of our work behind the scenes at CTAC has been focused more so on being a connector, connecting entrepreneurs and innovative companies that have a great idea to policymakers who need to make policy changes to enable these technologies to happen, or to payers who could really benefit from integrating this type of technology in a pilot. We would love to not only design policy to enable technology, but to do the dirty work in helping scale that as well by connecting local level entrepreneurs to the people who can help scale their tools. So with that, I'll stop, and I'm really hoping that the discussion is going to allow us to dig in more into some of these topics.
Thank you, Ravi. Well, so all three of you have mentioned, one way or another, have mentioned Medicare Advantage and the challenges of fee-for-service care, because MA can offer things that are not really medical care. They offer other things that improve people's lives and make them perhaps healthier and needing less medical care. But I'm going to start actually with a question to David, which, because David, the things you have talked about, and actually, Ravi and Susan can jump in on this too after, you're talking in terms of patient need and family need, but basically, what you do is venture capital. You raise money for for-profit companies. How does that mesh with the idea that we have a lot of equity problems in getting care to people who don't have resources?
So I think it's a really good question. And I think in healthcare, one of my core beliefs is that better care is generally more efficient care. In so many areas, the problems of delay, of treatment that does not reflect the needs or the wishes of the whole person, or of patients getting ping-ponged around and missing out on early care so that they need more expensive things later, are, those are the long time systemic issues. I think in this particular setting, and I'm glad Ravi mentioned, some of the infrastructure needs, because I think that's a whole separate opportunity set. the kinds of things that happen when somebody, Ravi or Susan, you may know, but my understanding is that the gap in access to hospice care for Black Americans versus non-Black Americans is about 34%. And there may be many drivers of that, but it's consistent with the other racial inequities that are much on our minds these days. It is highly unlikely that putting Black patients in that gap saves the system money. It's much more likely that there are more hospitalizations, there are more deviations from the wishes of individuals. That at least is my guesstimate. So, when we look at, how to, again, as a venture capitalist, how do you build profitable businesses out of this? Integrating care around predictive analytics, around knowledge of the individual patient and their wishes, is going to create better well-being in a lot of cases that will be less expensive. And then coming back to where you started, Sheryl, I'm sorry for the long-winded way, but under a Medicare Advantage chassis, where savings become a profit pool up to a modest amount, there's an economic model to pay for all this. So, and I'll just, one other point, if we wanted to talk about housing or broadband infrastructure in poor neighborhoods, once you start thinking about the healthcare costs and the education costs of lack of equity and fairness, there are lots of payment streams that could be brought to bear. So, all right, Ravi, can you translate that into better explanation, or disagree with it maybe?
I thought that was fantastic. I think that one of the advantages of Medicare Advantage and where a lot of our pilot work kind of works in is just the potential to innovate with even something as sort of including as a routine benefit, sort of routine home care, or being able to experiment with some of these home-based care solutions, technology-enabled solutions, even something as sort of potentially transformative but difficult in a fee-for-service system as giving people access to their own health data via a wearable device. These are the type of pilots that are enabled in a Medicare Advantage setting, and by extension in alternative payment model settings that have been really exciting for us as academics to get our hands on for the purposes of evaluating.
Yeah, and things like Signify or Humana's Your Home Advantage, these home visits for early assessments as they begin to identify social needs, loneliness and isolation, mold in the home. Again, there is a long way to go here, but again, there's savings associated with each one of them. Can I flip to ask Susan a question? Or Susan, do you want to say something? Sorry.
I was just going to jump in on what you and Ravi had to say about Medicare Advantage, because the reason I mentioned it is that it seems to be the space where CMS and is sort of defaulting to have some of the innovation that needs to get addressed done. But one of the challenges I think we have to look at with some of the Medicare Advantage programs, particularly the VBID carve-in of hospice, is there's not agreement on what quality care looks like. What we've defaulted to mostly is what we can measure. And there's always a challenge when you begin to sort of have this black box where you get this pot of money, you use it as you want to care for patients, but is there a difference when there's not a prescriptive approach to the quality and the outcomes versus do what you think you should? And payment reform is absolutely necessary. Payment motivates behavior. It instigates action. So we're not going to get anywhere without it. But I do worry a bit about making sure, particularly with serious illness care, there aren't agreed on standards for what is good care and what outcomes should look like. So I just want to put that caveat out there. I think that's an area that needs to work concurrently with the continued advancement of Medicare Advantage.
I agree. Could I ask you to, where do you, how do you think in that context about the better access to patients' patients' values and directives? I mentioned, cake, or these ideas that you can nudge people to be clearer about, what they want, because I could not agree more that not everything that matters can be quantified and measured, at least in ways we know about yet.
Well, David, that's an excellent question. It's the conundrum we face with end of life and advanced illness care. Most of us in our life will buy multiple cars, maybe several houses, but the first time you're having to figure out that there's more to your advanced directives than just whether someone will jump up and down on your chest and break your ribs, that's awakening for people, because most of us have not walked down that path. So I think advanced directives are the best tool we have at the moment. But one of the challenges, and we use the honoring choices, which is based on respecting choices, that I think is now part of CTAC, to really have those facilitated conversations. But you mentioned something important that I think technology can help with. Most of the time when people are interacting with the medical system and need their wishes to be understood, the document is not where they are.
Right.
And you mentioned something really important that I think I've seen a couple of applications where technology allows people to actually record messages to their family members to instruct them, so that if their particular scenario isn't within the lines of what they wrote, the family at least has directional guidance on what someone would and would not want. And I think medical providers don't want to do things that bring low value and may actually harm. But if there's contention and lack of guidance from families, they default to that because of the litigious world we live in. So I do think technology, that's an area of vast improvement, is to do a better job of advanced care planning and helping people direct care and having their surrogate decision makers understand what they want.
Can I make one point about advanced care planning and the quality measurement point that you brought up, Susan, because I think that's so key. Serious illness and advanced illness care isn't cardiovascular care. We don't have a great biomarker like a blood pressure or a cholesterol level that we're going to be able to use to judge the success of what we do. But so much of what we do, I think some of our quality measurement faults, to a fault, goes to what's easy to measure as opposed to what's right to measure. Take something like advanced care planning, which is a typical quality care metric and is so important to document someone's advanced care plan. I can't tell you the number of times that what is in someone's advanced care plan on a one-time basis that gets coded as a check mark either changes during the course of illness or doesn't get followed near the end of life because we don't have the technological solutions to translate what's in that paper into the actual routine course of care when someone's near the end. And so, I think that we need to, if we started judging some of these policy proposals and some of these technological solutions, not by just whether they check a box, but whether they're actually helping patients adhere to their goals and goal concordant care, then I think that we would make a lot of way into filtering out a lot of the fluff in what's been coming out in some of these technological solutions towards technology that can actually help make a difference in how we care for advanced illness. That's just one pet peeve around the quality measurement piece that's always bugged me about the advanced care planning being the surrogate for what we do in advanced illness and being the end all be all of high quality advanced illness care.
Ravi, you're so right. I think we treat advanced care as an event, not a process. And advanced care planning has to be a process. And there are pulse paradigms. There are things that get a little closer to it. But again, I think that's one of the big areas where technology can help us have more real-time information and more flexible information on what would really help a patient and align with their preferences.
So I have a question for each of you. I'd like you each to tell me, what if you see barriers to getting the right thing done? Are these public policy barriers, and what would you ask the administration to do?
Are they listening in now, Sheryl? Well, one of the things that I see coming from a background of community-based elderly care, and I was very grateful the Biden administration announced a large funding pool for home and community-based services, and they termed it a down payment. I think that we force people into choices because of policy that ends up becoming payment policy. Like, for instance, we'll pay for Medicaid nursing home care, but PACE programs that could keep people out of nursing homes. What do we have? 25,000 enrolled in PACE in the United States, even though it's a best practice. So my wish would be, we know what works. There's evidence out there, yet we tend to abandon it, walk away from it, only partially leverage the benefit. And I see that over and over and over again, and PACE is one of those examples. So my wish would be to really look at what works to deliver care at the right time and in the right location and at the right level. The VA has a great experience with that. And so there are solutions out there, but one of the things that I think is problematic is the will, as I mentioned in my opening remarks, the will to really disrupt the system and its business models that are based on what we do now, because fundamental change will be very disruptive to those business models.
So I've got two. One of them would be interoperability. It's an old, it's been around for a while, but keep pushing, because the kinds of specific information sharing changes that Ravi referred to, the needs, can only happen if we keep pushing on that. The other thing is, I'd love to see some bolder experimentation with payment for social determinants of health type issues within the premium. And this is a crazy idea probably, but instead of just sort of saying carte blanche, yes or no, lower the Medicare age to 60 or 55, how about having some experiments with predictable future costs due to substandard housing or food access, but get a health care cost avoidance model built up so you could issue impact bonds or goodness knows what, but try to do that in a improve at an earlier point of life level. Again, it would be small, it would be experimental, but so many of the experiments don't go anywhere, and there is a lot of avoidable behaviorally driven or societally induced costs that we ought to start working on how to get out. So,
yeah, I can't think of too much to add to that. The one thing I would say, and I know this is a panel on technology, and so I'll try to tie it in, but I think we need to make substantial reforms in the Medicare program, specifically Medicare fee-for-service, for how we pay for caregiver and community health worker support. I think that the fact that we rely on advanced illness care on a huge workforce of essentially unpaid labor when it comes to caregivers caring for their own family members, and to community health workers like faith-based leaders, faith-based communities, connecting their their congregations to a lot of the social connectors that are so responsible for how they interact for the healthcare system. I think that we need to figure out good ways to reimburse those. The process of reimbursing for social determinants, for reimbursing care that addresses social determinants of health, and having that live in the world of Medicare Advantage and small scale pilots and alternative payment models just isn't going to be sustainable. And so I think the way that technology feeds into that is that once we enable caregivers, community health workers to do what they do, they're going to be able to use technology in a lot more innovative ways to, for example, connect individuals to social supports in ways that they haven't been able to connect them before, or enabling remote caregiver support in caregiver counseling for difficult to navigate clinical situations that result in an emergency room visit. So, but that needs to happen in Medicare. Otherwise, we're not going to make a dent in the spending and the possibilities that this type of care has to offer.
So we've talked a lot about Medicare, and we wanted to think about everyone has touched on, what's equity? What about equity for people with, who don't have the resources, to spend? And, we have a program, Medicaid, and I think I heard it said that Medicaid doesn't have the flexibility that Medicare does. Yet that's the program that covers, a lot of people who don't have resources to get better care somewhere else. So what could we do there?
Cheryl, there's tremendous variability state by state because of the way Medicare is structured. So some states like Louisiana have actually done some very good things with the waivers that are available from the federal government to do home and community-based services. But when you look at state by state, there really hasn't been consistent innovation in Medicaid and how it cares for people, and it really there's no central impetus for it like you see coming from Medicare. I think it is an issue of equity because there are things within Medicaid like special needs plans that can address more comprehensive care to people with certain diagnoses like end-stage renal disease. But in general, I think variability is the big problem with Medicaid and a state's interest in looking at innovation or how it's using those dollars and how many people are being covered with those dollars. So in Florida, for instance, we have a lot of gaps. And it depends on what state you live in, which is it's kind of a shame in this country that it has to be that way. But that's been my observation. Depends on where you live, whether your Medicaid is going to help you or just be there as a residual when you need only a nursing home.
Yeah, I mean, Medicaid is not one program. First of all, regardless of which state, it's a bunch of different things depending on sort of your age and needs and, kind of time of life. I guess I would say the special needs plans that Susan started with, at least in the case of elders or people with clearly advanced care needs, that would be the place to start. But the hodgepodge nature of it, the short-term contracts with the managed care organizations are those are impediments to to work through. And I do agree very much that that it's quite behind.
Completely agree.
Yeah.
So we're getting to the point where we have to wrap up.
Uh-oh.
And I wanted to ask you to think about this. If you had one key takeaway. I mean, we have an audience here who's stuck with us for the whole conversation. And if you had a takeaway for them, if you were, if you did use Twitter, what would you put in a tweet? What would you want people to think about, act on, remember from this conversation?
You saved the toughest question for last. Thank you. Well, if I could wave my magic wand and be queen of the world, I would say that we have both the ability and really the responsibility to help our system evolve from a payment-centered system of care to a patient-centered system of care. We know what works. We just have to find the will to do it. And I think economics and demographics are going to make the thought of those changes less scary than status quo will look like very soon.
So I would try to bottle up what I heard from Ravi into a tweet, and I can't get it in a tweet. So I'm just going to say what I heard, Ravi, was, everyone has told me, over the course of the pandemic, oh, aren't you glad your parents passed before the pandemic began? And of course, the loneliness and the sadness and all of the horrors of, I know what people are talking about, but the way you described your practice as changing and the kind of integrated outreach, that to me gives me enormous encouragement. And the notion that the fright of the virus has spurred that kind of transformation, I take as just tremendously positive and encouraging. And I hope out of that will come maybe comfort to a whole lot more families and and patients. So, all right, I set you up.
I love that. Yeah, now on Twitter you can do threads, so you can have multiple tweets. Mine might be multiple tweets, but I would say that in summary, technology is here to stay in the way that medical care is delivered, and hopefully it'll be integrated in the way that care and addressing social factors is delivered as well for our advanced illness population. The one thing I didn't get to comment on that I would probably put at the bottom of the tweet is for those who want it, because I think that there's still a lot of reluctance to embrace things like telemedicine, wearables, that kind of thing for a lot of populations that spans across different types of races, ethnicities, things like that. And so one potential disadvantage of the pandemic is we forced some models of care on the people. For example, right, deferring 100% of primary care to the telemedicine setting. That can't stand, because there are people who want to come into the clinic, there are people who need to come into the clinic, there are people who need face-to-face encounters for how they prefer to deliver care. And we've got to meet those folks and where they are too. Otherwise, we're going to enforce a whole new set of disparities on the people and cause a lot of other distrust in the system.
Wow.
Wow, well said.
This has been a great hour, let me tell you. I guess I have to wrap up now. This is the first of our sessions on technology and on how trends are transforming advanced illness care. I hope people will come to the rest of them. I don't know, can I promise as engaging a set of panelists as we've had today? I hope so, but you guys have been terrific. I want to thank you. I want to thank our great hosts and collaborators at the Petrie-Flom Center who made this event possible and run smoothly. And then my colleagues at CTAC, of course. Again, and I have to close by saying if anyone is interested in learning more about our work on advanced illness, you can join our free virtual policy forum on May 12th. And as Carmel said at the beginning, it was on that initial slide, but you can also go to thectac.org. That's THECTAC.org. So thank you, everybody, and we'll see you soon.